Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello, everyone. I'm Charu Agrawal. I'm the Leslie Heisler Professor for Lung Cancer Excellence and Section Chief of Thoracic and Head and Neck Cancer at the Abramson Cancer Center at University of Pennsylvania. I'm thrilled to welcome you to this discussion titled Expert Panel Decision Framework, Progressive Strategies for Managing HER2-mutant Advanced Non-Small Cell Lung Cancer. Introducing faculty is always a pleasure. I'm thrilled to be joined today by Doctors Umberto Malapelle and Herbert Lung. Umberto, would you like to introduce yourself?
Hi, everyone. Thank you very much, and really pleased to be with you and to start with this discussion.
Hi, I'm also very happy to be part of this discussion. My name is Dr. Herbert Long, and I'm from Hong Kong.
Welcome. Thank you so much. And we're going to talk a lot about HER2-mutant non-small cell lung cancer. We are going to take a multidisciplinary approach. We're going to share expert insights and perspectives on not just testing, but recent clinical trial data for HER2-directed therapies, key decision points in care for patients with advanced lung cancer, and then discuss how to interpret biomarker reports to guide therapy and how to select the most appropriate treatment approaches for patients with HER2 mutant advanced non-small cell lung cancer. We know that HER2 mutations are present in non-small cell lung cancer. These are clinically actionable, most commonly found in patients with adenocarcinoma histology, usually in patients with never or light smoking history. We find that these may be more common in patients with an Asian heritage, although that should not stop us from testing all patients with non-small cell lung cancer, especially with adenocarcinoma histology. Women can have a higher incidence and prevalence of HER2 mutations. And we know that the testing for HER2 mutations is now included as per the NCCN guidelines, the ESMO guidelines, as well as the ASCO guidelines. Um, Umberto, I'll move on and talk to you first about how we can optimize testing for HER2 mutations and identify patients early. How have you incorporated testing, and if you can walk us through this?
Thank you very much, Charu. This is, as you know, and a really important point because we need to consider that HER2 is a really relevant biomarkers in the context of the other biomarkers that we need to test for patients in the same setting with non-small cell lung cancer. And so this means that for sure, from technological point of view, the best strategies remain next generation sequencing because we are able not only to simultaneously evaluate all the genes that we need to evaluate, but within the same gene, and in particular case for HER2, we will be able to cover all the relevant alterations because we are talking about on a plethora of different alterations that can happen in the TKD domain, so tyrosine kinase domain of a HER2. And it's so relevant also to capitalize the source of materials from biological point of view that we have, and then we can proceed with this type of assessment on tissue and also in liquid biopsy when we need.
That's right, Umberto. And now in lung cancer, we have to look at HER2 mutations, but we also have to look at HER2 IHC. How do you operationalize testing for this? Because, HER2 IHC is something that we can't glean from liquid biopsy.
This is another relevant point because for this we need to capitalize the tissue source that we have for these patients because HER2 is the prototype of the complexity in terms of the diagnostic strategies to evaluate and biomarkers and giving us also the opportunity to fully exploit the terms agnostic, no? Because in this case, we have the same biomarkers, but we need to evaluate different characteristics by using different technologies. When we are referring to the overexpression of the biomarkers, the golden strategy is represented by immunohistochemistry on tissue as evaluated within the clinical trials. Then when we need to evaluate mutation in HER2, we are referring to genomic DNA in this case that can be extracted from neoplastic cells content on tissue and also from liquid biopsy. But for sure, when you need to evaluate both, you need to capitalize the tissue source for the hyperexpression evaluation by using immunohistochemistry. And on the overall, you can have other type of strategies evaluating also the amplification in some genes, and in this case, another time we need to refer to tissue by using other type of strategies like as fluorescence in situ hybridization and so on. In particular, for HER2, as you highlight, Char, we need to address the question regarding the mutation on DNA, and then we can search this on genomic DNA extracted from tissue and liquid biopsy, the so-called circulating tumor DNA. On the other hand, for hyperexpression, we need to use immunohistochemistry on tissue.
Right. And just to summarize, very important to still look at NGS, which can be done with blood and tissue to look for activating mutations. And then, in addition to that, for expression, we need tissue to look for IHC. At our institution, we obtain tissue NGS on all newly diagnosed patients with advanced lung cancer. We will send complementary plasma testing as well, and also have initiated testing for HER2 IHC. Herbert, how are you operationalizing this at your institution?
Yeah, thanks for the question. So for us, actually, I think over the last year and a half or so, we've also done reflex NGS for our newly diagnosed non-small cell lung cancer patients. We actually use a smaller panel, a 52 gene panel for our locality, but we also realize the importance of establishing these biomarkers early to make sure that we're able to channel patients into appropriate treatments. In the Asian population, what's interesting is we have a predominantly EGFR population. So in actual fact, we actually previously did a cost effectiveness study looking at whether or not it's worthwhile doing upfront NGS for all our patients or potentially do an EGFR PCR test first, which is a quicker turnaround, and only those which are negative then say do an NGS. We've proven that it is actually cost effective to do it that way. But at the same time, given the fact that NGS testing, the prices have come down quite significantly, and we do want to get a bigger spectrum in terms of accessing the different actionable biomarkers, we've decided to do an upfront NGS for our patients.
Fantastic. All right. Umberto, just a word on liquid biopsy. Tell me how you think this may be actually meaningful in selecting the right patients for HER2-directed therapies.
Thank you again, Charu. As we have also previously addressed, for sure we can use liquid biopsy also to test HER2 mutation. And we can use liquid biopsy in three different ways in this setting. And in example, in my country, the first one that is the sequential approach is the preferred one. So we start from tissue. If the tissue is enough, we proceed with tissue-based approach. If tissue is not enough, we proceed with liquid biopsy. But in your country, as you highlighted before, also the complementary approach. And this is my personal opinion. This is the best approach that we can use also to reduce the turnaround time. Because in this case, when you have a sequential approach, you need to wait the results on tissue and then you can start. But if you would be able to use in parallel strategies by using tissue based and then a liquid biopsy based approach also for HER2 represents the best strategies that you can. In particular, we are talking of liquid biopsy, but for sure only on ctDNA as analytes. So in this clinical setting, ctDNA represents the gold standard for this type of evaluation. Because as you know, in other chapter of this history regarding the translational research, there are many studies evaluating the hyperexpression of HER2 on circulating tumor cells, but we don't have clear clinical indication of this introduction in clinical practice. For this, we are referring only to ctDNA evaluation of HER2 mutation in this setting. And the key weapon is to combine the approach, as we have said. So to take in mind the power that we can have starting from tissue and the power that we can have in our end starting also from liquid biopsy. If you can in parallel, this is better also in terms of turnaround time for our patients.
Absolutely. And I think this speaks volumes for tissue stewardship. I think if we can get an answer from plasma testing, we can then save our resources for tissue for other ancillary testing that may become more and more important as we introduce additional biomarkers. All right. So, what are the essentials that clinicians need to be aware of in interpreting the molecular diagnostics report? Umberto, from your experience, there can be some variations in how HER2 is reported. Can you talk to us about what should be in the report? How should this be analyzed?
This is the third pillar of this history because, in example, in the lab you have three pillars. The first one is the pre-analytics, the second one is the analytics, and the third one is the post-analytics. And the post-analytics is the points in which lab is in contact with the clinic. So it's so relevant to have a real clear and real structured reports, in particular for the genomic variants as in this case, because we can put in a report, in example, an C.2327G plus A, but this can be formally correct, but completely not clinical understandable. And so in this case, it's convenient to report that we have detected an hepathogenic variance in HER2 and then give you the possibility to stratify the treatment. For this, we have suggested also at international and national level to have a report in which the diagnostic session is highlighted with the only clear clinical information reported with the UPAC nomenclature and with the actionable scale of the country in which you are. So, an example, in the US, you have the tier 1 classification of these variants. In Europe, we have the ESMO SCAT scale classification of these variants. So, this means that we need to fully conjunct the nomenclature that comes from the lab and the clinical action that you can start by using this type of information. For this, the ideal report is in three sections. The first one is the anamnestic part for our patients, in which we can retrace all the information regarding the patients. The second one is in a really summarized section on the methods that we have used to verify if there is or not a possibility to proceed with NGS, in example. And the third one, the clinical interpretation of the variants that we have detected, referring to the scale of the countries that is approved in the countries in which you are working for. And this is the dreaming structure of the report that we can have to have a fully clear discussion with the lab and clinic.
Absolutely. I think many a times an actionable mutation can be missed if the report is not clear. So I love how you laid it out that the first thing should be the clarity of the report and the interpretation so that it can be directed into actionability. So now that we've covered HER2 testing, it's important to look at, of course, HER2 mutations as well as HER2 overexpression. Herbert, I would love to discuss with you current evidence for HER2 targeted therapies and what it can mean for our clinical practice. So, as you know, we have three approved agents targeting HER2 mutant advanced non small cell lung cancer in the second line setting and beyond. Let's first start off with antibody drug conjugates. Can you talk to us about evidence for trastuzumab deruxtecan?
Sure. So I think to begin with, the evidence for a HER2 positive non-small cell lung cancer, it all started with the Destiny Lung 01 trial, which was one of the first trials in this therapeutic space, where in the HER2 mutated non-small cell lung cancer, they actually found that there was a high response rate of about 55% and also a good progression-free survival of upward of 8 months. But interestingly enough, at the recommended dose of 6.4 milligrams per kilogram every 3 weeks, they also realized that there was a high incidence of pneumonitis, and that was actually up to about 26% of the patients who were subjected to this dose in the study. And that led to the Destiny Lung 02 trial, which is actually the trial which also led to the approval of trastuzumab deruxtecan in this therapeutic space, where they actually randomized patients with HER2 mutated non-small cell lung cancer to two dose levels. One is the 6.4 milligram per kilogram every 3 weeks, and also a lower dose of 5.4 milligrams per kilogram every 3 weeks. And what they found essentially is very similar responses and very similar duration of response, but a clear difference in terms of the toxicity profile. And the higher dose, and that is therefore the recommended dose to move forward. And certainly that is the on-label dose for use in this particular setting. And aside from the lower toxicity, what they've also found is the fact that the response rates are somewhere in the range of 50%. and a progression-free survival of about 10 months for patients on the 5.4 milligram per kilogram dose, and an overall survival of about 19 months. Some more common side effects are the side effects that we see. Nausea includes vomiting and some gastrointestinal side effects, as well as neutropenia and other myelosuppressive side effects as well. So these are generally handled with, say, dose hold and dose reductions. And in general, with all that sort of supportive measures, patients are able to tolerate the treatment fairly okay.
Yeah, and these antibody drug conjugates, I think, especially in patients with HER2 mutant non-small cell lung cancer, do have significant response rates. So I think it's a matter of modulating the toxicity, monitoring for ILD, and dose interruption and dose holds, as well as dose reductions, are incredibly important to help patients stay on these therapies for a long time. Herbert, you've been involved in development of tyrosine kinase inhibitors in this space as well. We now have zongertinib and savabortinib. These are two novel approved HER2 TKIs. What are your perspectives on how their efficacy and safety profile might influence you to use those over trastuzumab deruxtecan? Can you compare and contrast some of the data?
Yeah, sure. I think in the last 1 or 2 years, we've seen an explosion in terms of the data for both of these tyrosine kinase inhibitors, zongertinib as well as savabortinib. Um, Although they're both tyrosine kinase inhibitors targeting HER2, there are distinct differences in terms of their pharmacodynamic profile. So to begin with, zongertinib is actually an irreversible covalent binding compound binding towards the tyrosine kinase domain, and it is actually very specific for HER2. Whereas savabortinib is a reversible tyrosine kinase inhibitor in terms of binding, and in actual fact, it targets both HER2 as well as EGFR. And in its initial phase 1 trial, we were actually also recruiting EGFR patients as well. But certainly we saw the efficacy in HER2, and therefore it's been dedicated to HER2. And given the fact that there are these two differences between the two compounds, there are also differences in terms of its toxicity profile. So specifically for zongertinib, we do see potentially a bit more biochemical or liver toxicities, at least based on the clinical trials, as opposed to savabortinib. But at the same time, for patients who are treated with savabortinib, we are seeing some EGFR-like toxicities, including, say, some skin toxicities, such as acneiform rash and mucositis, as well as it does seem as though diarrhea is a common problem between these two agents. There has been no head-to-head comparison between these two, but numerically, based on the clinical trials, it does seem to be a little bit more common in patients who were treated with savabortinib as opposed to zongertinib. But certainly, I think, again, these toxicities are also potentially manageable with, say, dose hold and dose reduction. And certainly, I think these two agents have actually really improved the therapeutic landscape for patients with HER2-mutated non-small cell lung cancer.
And there's so many cohorts here, right? Zongertinib and savabortinib. You highlighted the toxicity differences, but does efficacy look very similar for these in the second line setting, Herbert?
Yeah, there's so many cohorts and it's so confusing in all honesty. But I think the bottom line is the efficacy do look quite similar for these two agents. So let's go for zongertinib first. And you may be aware that there are 5 cohorts within that phase 1 clinical trial. And we're always interested to look at the patients who have had prior treatment, the patients who are treatment naive, as well as patients who probably had a prior HER2 ADC. And these are the 3 cohorts that many a times we focus on. And the response rates essentially for patients who were pre-treated were about 70 to 72% with chemo previously. But for patients who were pre-treated with a HER2 ADC, the response rate had been quoted at something lower at about 48%. So, of course, the other agents that we have is savabortinib, and there have also been phase 1 clinical trial known as the SOHO-1 study, where again, there are multiple cohorts being investigated. And in terms of the results, again, there are these cohorts, including cohort D, which are actually patients who have previously had chemotherapy, but never had any HER2-targeted therapies. And in actual fact, the response rate is around 64%. And there were also patients in cohort F, which was treatment naive, and there was a higher response rate of about 71%. But again, also very interestingly, in the patients who've had a prior treatment with HER2-targeted ADCs, which is actually cohort E, the response rate is actually slightly lower at 38%. So I think it's quite interesting that these results are quite similar to what we see in the zongertinib data as well. So essentially, what we're seeing is a fairly good efficacy. And if we want to draw a parallel, I guess, to other actionable mutations within the non-small cell lung cancer space, I would actually equate our current first generation TKIs for HER2 mutations to be as good as any other of the first generations and other actionable mutations, probably even as good as second or third generations in terms of its efficacy, in terms of response, as well as duration of response as well.
Thank you for outlining. You're absolutely correct. There are just so many cohorts, but reassuring to know that these drugs are effective post chemotherapy, post ADC, and now HER2-directed therapies are being investigated in the first line setting. Herbert, based on what we know so far, what are the implications for clinical practice? I know sevabertinib was also looked at treatment naive, as zongertinib now. How do you use these agents and how do you look at this data?
Yeah, I think with the recent approval of zongertinib in the first line space, and certainly again, this is due to the promising data that was shown in the phase one study. I think the decision of whether or not we use, say, zongertinib first or potentially sevabertinib when they get their indication versus, say, trastuzumab deruxtecan, I think it boils down to several factors. I think to begin with, the ease of administration. Certainly, I think an oral agent is generally what's preferred by most patients. But at the same time, there are situations where you might want to consider using an IV agent if, say, there are very severe side effects and toxicities, say, with the diarrhea, which does not seem to be controlled by, say, dose reduction in that particular patient. I think ultimately, based on what we see as well, is in the two cohorts of the two trials where patients have been treated with an ADC beforehand, you do see a lower response rate. So based on that, I feel that maybe it's worthwhile using, again, the oral agents first. And then upon disease progression, you may consider using an ADC. And I think also mechanistically, if you think about how these drugs actually function, in a way, as long as the cells are have HER2 mutation, or later on we're talking about overexpression, so expressing HER2, then potentially the ADC will work regardless of whether or not they are still dependent on that particular molecular pathway for its growth. Whereas, of course, if you're using a TKI, it has to target that particular molecular pathway. So I feel as though the ADC might have a better role in covering, say, resistance to TKIs. I don't think there is clear data to support this, but I think just mechanistically, it does seem as though we can consider using ADC at a later line.
Yeah, you outlined this really well, and this mirrors some of my thinking. I think oral therapies are preferred by patients. They're definitely easier than getting an IV infusion every 3 weeks. Are there other patient-specific factors? We haven't talked about brain metastases. Herbert, what are your thoughts about that?
Yeah, I think we're seeing emerging data about the efficacy in patients with brain metastases for these two oral agents. So certainly with trastuzumab deruxtecan, there have been already published reports on its efficacy in brain, and it does look efficacious. I think at the same time, in these two oral agents, we have specific cohorts looking at patients with brain mets. What we do know is there is activity in the CNS for both of these agents. But I think at the same time, we might want to wait for the actual cohort of patients and the cohort data to really decide. To me, if I have essentially all three agents available, I would also consider using a TKI first. I would think that there is a good chance that these small molecules can pass through the blood-brain barrier, and we have seen efficacy in the early phase clinical trials. But again, the actual cohorts where they're dedicated to look at this specific population, the results will be presented at upcoming meetings.
There's a lot to consider. I think the ease of administration, the brain penetration, as well as avoidance of ILD. I think with ADCs, we are understanding that almost all ADCs have some risk of pneumonitis. In my practice, I have become extremely cautious in terms of looking at scans, even in the absence of clinical symptoms. If I have a radiographic finding, I'm very, very cautious and I will hold the dose. Herbert, do you think about ILDs as a limiting toxicity for you to preferentially use TKIs?
I do, and I think the problem with ILD is certainly it can be life threatening, and sometimes, as you've mentioned, it can be completely asymptomatic. I wouldn't say it's a dose limiting toxicity, but it's a treatment duration limiting toxicity for patients who are treated with ADCs. And therefore, again, if I have a choice, I would potentially consider using a TKI first in such situations.
Absolutely. I mean, I think both classes of drugs have their toxicities. We have the diarrhea and the LFT abnormalities with the TKIs, but we have to be aware that there can be life-threatening toxicities such as ILD. And it's important to remember that as opposed to immunotherapy, if somebody who's been treated with a trastuzumab deruxtecan-like agent or an ADC, any grade 2 toxicity calls for complete discontinuation of the agent. In the immunotherapy world, we may say grade 2 toxicity, I may give the patient steroids, and if they recover, I may actually re-challenge. But that would actually be the wrong thing to do with ADCs. That's why I take this so seriously, Herbert. I'm glad you pointed it out. Grade 1 ILD is basically just radiographic presentation without any major symptoms, and grade 2 is symptoms. But grade 3 is symptoms along with oxygen requirement or a need for inpatient hospital stay. So I do think that we have to be, as physicians, extremely cautious so that these ILDs don't turn to be fatal. Well, this has been a really great discussion. Umberto led us with testing on HER2 mutations as well as overexpression. Uh, Umberto and Herbert, I'm going to ask you quick key takeaways. If you can summarize two things that should stick with our audience, and what are you most excited about? So, Umberto, I'll start with you.
Thank you very much. So test for all your patients. Uh, Use all the power that you can have from tissue and liquid biopsy, taking into account that you have some differences when you are focused on mutation and then hyperexpression and amplification.
Herbert?
I think for me, certainly it's a very exciting time in this therapeutic space. We have three active agents that we can consider aside from chemotherapy. I think interesting component or the decision making of what goes first and how you sequence this is going to be something that's going to be answered in the coming 1 or 2 years as we see more and more clinical trial data, more clinical experience. What I'm interested and excited about are two things. One is I think as we progress and have more experience of using these agents, identifying the resistant mechanisms of these agents may actually help us then decide which should go first and which should go next, because one may cover the resistant pathway of another. And I think the other is right now we're looking at these HER2-targeted agents in isolation, but is there potential to combine it with some of the other established treatments that we have already? And whether or not that may even bring better efficacy. So I think, again, we'll have clinical trials upcoming which are looking at that, and I'm excited to see where this will lead us.
I'm equally excited about the prospect of using HER2-directed therapies in our practices. As you know, I'm a big proponent for biomarker testing. So this, I think, gives us the opportunity to use biomarker testing and actually apply it to clinic. I would love for the audience to identify one patient in their practice who could benefit from HER2 testing and subsequently targeted therapy this week. I think in the future, we'll be looking at combination therapies. I would be very excited about the prospect of ADCs in combination with TKIs, the first line setting. I think chemotherapy free approaches, as you pointed out. I think the future is bright and I'm really excited. Umberto and Herbert, thank you for this great discussion and educating us about not just testing, but application of targeted therapies. Thank you. And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.